The first talk is entitled No More Triple Negative Breast Cancer, the challenge of tailoring treatment in the advanced setting, and will be offered by Dr. Rebecca Dent from the National Cancer Center, Singapore.
Great. I want to thank Mafalda and Sonia for your kind invitation, and of course Salty, to present this exciting meeting, and hello to all of you who are attending virtually. So the title of my talk is No More Triple Negative, the challenge of tailoring treatment in the advanced setting. So what do we know? We know that we're treating an ER negative, PR negative, and HER2 breast cancer. We've known for a long time that this is a multi-level, genomically complex breast cancer, and that it's a chemo-resistant breast cancer, especially in the metastatic setting. It just happens to be ER, PR, and HER2 negative. These are my disclosures. So it was about 20 years ago, published in Nature 2000 by Chuck Peru and Teresa Sorley, entitled Molecular Portraits of Breast Cancer. So using first generation next-gen sequencing, they helped identify for us that breast cancer is extremely heterogeneous. And what they identified was that there was a subgroup of patients that just happened to have low ER expression, low HER2 expression, and that was usually triple negative. It expressed cytokeratins that were found in the basal layer of the breast, as compared to luminal breast cancers that express these luminal keratins. It's very proliferative, very often had p53 mutations, and evidence of genomic instability. So what happened was the world took off. We as doctors and as humans love to have categories. We love that we could call this group of breast cancer patients something. So it was called triple negative because clinically they are often ER, PR, HER2 negative. So you see here this explosion of research, now almost 14,000 papers published, cited in PubMed, from 2006 really up to 2000, here you can say halfway through 2020. Now, we're all guilty of using this, we'll say, definition of convenience. So my colleagues and I in Canada in 2007 published this paper that, my boss at this time said, this is very simple. This is just using IHC to define a subgroup. And I said, yeah, but clinically it's quite meaningful. And really what we saw was that in the early breast cancer setting anyway, triple negative breast cancers were twice as likely to relapse and happen twice as quickly. And now that was important for identifying an early breast cancer, that we have to have a lower threshold to give chemotherapy. And as we've learned, in ER positive, we're over-treating many patients. But I have to say, I guess my boss was right, because just after that, Alex Pratt and Chuck Peru published data that tell us that when you're looking at triple negative in the clinic and you're looking at IHC clinical assays, ER, PR, HER2 negative, when you actually look at these with molecular assays, 3/4 of them are molecular appropriate, but 1/4 aren't what they seem. So 10% are actually HER2 enriched. So you could argue that these are actually being mistreated, because we know that if you have a HER2 enriched breast cancer patient, those patients do very well with HER2 directed therapy. So this was an important lesson to learn, and we continue to learn. The other thing is, we know that this group of patients that are 1 to 10% ER/PR positive, this borderline tumor, which is really sort of an orphan group of patients that often aren't eligible for triple negative, and we aren't really comfortable putting them on ER positive trials. But this work from Maggie Cheng many years ago showed us that in this group of patients, about 29% of them are actually HER2 enriched. So again, a very difficult group of patients to understand. So you see the ASCO CAP and other guidelines have changed over the years, this way, that way, and the most recent 2020 guidelines, the panel came up with the fact that ER low positives, there's not really enough evidence to really show us that they benefit from ER directed therapy. So they came up with this new category of ER low positives, so 1 to 10%. And that I would argue that as we move forward, further correlation is needed with targeted therapies, and we need the biologic readout to make sure everybody's getting the right treatment. So we've also seen this heterogeneity in HER2 positive breast cancers. And again, here, Alex Pratt showed us that there's this discordance between the expression of genes and the way we measure protein expression of genes. So if you look at this clinically HER2 negative breast cancers, about 7% of those are actually HER2 enriched. So if you're looking at just IHC measurement, this may be a poor reflection of functional biology. So where are we at in 2020? Well, we have this, we're going to talk about metastatic low ER PR HER2, or triple negative. I can say that it was a definition of convenience that many of us adopted to define breast cancers that were ER low, HER2 low. And it was really just because these are the proteins that we knew to check for and that we had viable targeted therapies. But as we know, chemotherapy has been the mainstay. Technology, though, has helped identify that breast cancer across all subtypes is heterogeneous. Look at ER positive breast cancer, look at HER2 positive. It is very heterogeneous, and Metabrick has been one of the groups that have showed us this. So how have we got here? Well, because there's been an evolution in breast cancer classification, and again, applying these new technologies. From a morphological diagnosis, the ability to do protein expression with IHC, first and multiple generations of next-gen sequencing, and now we're able to do multi-omic analysis. And I think this is where the future is identifying pathways, not just one biomarker, and finally, our ability to do immunoanalysis and looking at these different immune subgroups. So as we know over the years, there have been several attempts to, again, subtype triple negative breast cancer. Brian Lehman and Jennifer Pietenpohl's group and Michael Bernstein. And this, the most interesting, I think, is when we're combining DNA profiling and RNA-seq, we come up with these 4 groups of triple negative. The luminal AR, the mesenchymal, the basal-like immune suppressed, known as BLIS. These are the patients with the worst prognosis. Can we convert these from cold to hot tumors and make them susceptible to immune checkpoint inhibition? And then the basal-like immune activated, the BLIA. So ironically, these are the ones that have the best prognosis and yet are also the ones more susceptible, again, to immune checkpoint inhibition. So again, I want to highlight and help us understand these different subtypes. So the luminal AR subtype actually displays mutations that are actually similar to those of luminal B breast cancers. So what you see is frequent mutations in PIK3CA, AKT1, again, that are similar to luminal B. They're actually different from other triple negative subtypes. And there's been actually data looking preclinically at this LAR subtype, so LAR subtype cell lines that actually show they're susceptible to CDK inhibition, just like luminal B. So I think as we explore these subtypes more, we'll actually find more and more targets that target these different triple negative subtypes. So similarly, I think it's important to understand the immune microenvironment. So our pathologists showed us well over 50 years ago that there was this group of breast cancers, not just triple negative, that have this lymphocytic infiltrate that has prognostic impact. Later we realized that it's been coined the word TILs, and we also know that there's this idea of predominant lymphocyte, predominant breast cancers. But we've learned it's not just lymphocytes, it's these different subgroups, subtypes of lymphocytes, looking at exhausted T cells, myeloid-derived stem cells, and actually they disperse themselves differently in ER positive and ER negative. So whereas some of these immune subtypes actually portend a good prognosis, let's say in ER positive, function very differently in ER negative. And this likely reflects the differential response we see to therapies, such as immunotherapy. And so the TCGA, looking at multi-omic profiling, has been able to help identify for us. So this is all tumors, so 10,000 TCGA tumors have looked at these different immune subtypes. And what you can see is it's all been integrated so that you can see here on the bottom, you have the TGF beta dominant. So this is the patient population with the worst prognosis, highly resistant, that probably needs combination therapy. As opposed to here, the C3, the inflammatory, that clearly has the best prognosis. And so looking at ethnicity, I think we've realized that there are some potential differences in ethnicity. And so it's important to look at these subtypes of triple negative. And again, it probably should be ER weak and HER2 weak. But in fact, even at AACR recently, there was some data looking at African-American patients and actually showing that the microenvironment in those patients actually may be different from Caucasians and different from Chinese. Now, in this study, actually from our colleagues in Shanghai, where they looked at multi-omic profiling, what they showed is that the LAR subtype has more ERBB2 somatic mutations and CDKN2A loss, again, making it potentially susceptible to different treatments than your other triple negatives. And perhaps, and what they also saw was more PIK3CA mutations and chromosome 22q11 copy number gains, and that's then compared to the non-Asian triple negatives that were reported in the TCGA. So before I get into some of the more specific tailored treatments, I wanted to highlight this really impressive publication, which is Ana Garita Castro, who's originally actually from Spain, who trained in Madrid and Barcelona, who's now at Dana-Farber. And why I think this is a great paper is that it highlights that it's not just one biomarker, it's not just one mutation, it's the idea that it's the pathway. And there are different ways of identifying this pathway, looking at the transcriptome, proteome, genome, epigenome, looking at the immune microenvironment. So understanding that there are these pathways, that these pathways overlap, but also under selective pressure of different treatments, the microenvironment might change, and that there are certain treatments that actually may change that microenvironment. So for instance, I'll speak in a second about how PARP inhibition might activate the STING pathway and therefore make patients more susceptible to immune checkpoint inhibition. Similarly, when we combine AKT inhibition with immunotherapy, again, you may be converting a cold tumor to hot and be able to amplify the immune response. So I urge you to take a look at this paper. So coming back to the clinic, so are there clinically relevant subgroups? Can technology guide us? So my colleagues and I in Singapore came up with this a couple years ago where really these were sort of theoretical clinically relevant subgroups. And what's great is now actually we have a test for each of these categories and we actually have very near or already approved treatments in these different groups. So I'm going to start talking to you first about the group of patients that really don't have anything identifiable. So mainstay is chemotherapy. And as we know, these chemotherapies are not that different compared to other subgroups of breast cancer patients, with the exception, which I'll talk about in a second, is the topoisomerase 1 inhibitors, the new antibody drug conjugate. Now, I think for some time we've been talking about this category of patients that have defective DNA repair. The best way to identify these patients clearly has been by doing germline testing and identifying BRCA1 and 2. There's been some attempts at looking at somatic BRCA mutations. Attempts at identifying a good HRD assay have been a little bit more challenging, but now we're also looking at beyond BRCA. So what's the data here? Well, first of all, if you look at these different pathway analysis, so as I said, there are many groups trying to come up with these signatures. They've all identified a subset of triple negatives that do have DNA repair deficiency. And so many years ago, Andy Tutt embarked on an important pivotal trial, the TNT trial, platinum versus taxane in advanced triple negative or BRCA1 and 2 breast cancers, looking at platinum versus docetaxel in almost 400 patients. And what he showed with his colleagues was that in the germline patients, we clearly saw a doubling in the response rate, as you can see here. So clearly germline BRCA status selected out the patients that were more susceptible to platinum in the first line setting, metastatic. As compared to the germline, no germline BRCA patients or the HRD assays, there was no difference between platinum and taxane. Now, this is an important point because it doesn't mean that taxane was better. It just meant that that was similar. So that means that platinum should remain in your armamentarium of treatments for metastatic disease. Now, in terms of median PFS, there was also an improvement, but unfortunately responses for germline were not as sustained as we'd hoped they would be. But certainly in terms of response and PFS, it was superior to taxanes in the germline BRCA patient population. Now, for many years, we've been embarking on the role of PARP inhibition across several tumor types, and certainly in the phase 1, there appeared to be germline BRCA patients that were heavily pretreated that had benefited from a single agent PARP inhibitor. These were the two registration phase 3 trials. One was the Olympiad that looked at olaparib versus standard of care chemo. The other was Embraca looking at talazoparib versus chemotherapy. The highlights from these trials, this wasn't just first line, this was a lot of the patients were actually second and third line. The main important part of these trials is that there was no platinum in the control arm. And that's really for the main reason that it wasn't actually standard of care at the time. The other thing to comment on is that in the Olympiad trial, there were less than or equal to 2 prior lines of therapy, and in BRCA, there were slightly more first-line patients. Nevertheless, both of these studies clearly showed an improvement in progression-free survival of almost 3 months in favor of PARP inhibition over standard chemotherapy. So this was a big win in the breast cancer world to show that a single agent pill could be better than chemotherapy, and we've obviously seen improvements in quality of life as well. Now, the things I want to point out about this study are that, first of all, it wasn't just triple negatives because it was BRCA1 and 2, but half the patients were actually hormone positive. So this isn't just a treatment for triple negatives, but for germline BRCA patients. And I think the other important thing is you clearly saw quite an impressive response. So 60 versus 30% in both of these trials. The issue is that the response, again, wasn't as sustained. And so far, the overall survival data did not show a clinically significant statistical difference. In the olaparib studies and Olympiad, Mark Robson last year showed us in early breast, in the first line setting, there did seem to be a trend. But again, as I said, in the ITT population, there didn't seem to be a difference. Now, what about beyond germline? So this is Melinda Talley and Josh Gruber's work that was presented last year at ASCO, where they looked at beyond BRCA, so looking at germline and somatic mutations in homologous recombination pathway genes. And I just want to highlight here the germline PALB2. And here you clearly see responses. Mark Robson showing the same thing. So I think we're looking to more somatic and other HRG genes in the future. Now, next, looking at the androgen receptor positive breast cancer. So this represents a pretty tiny subset of patients that are triple negative. There were attempts to do studies. There were a few single arm phase 2 trials that clearly showed a benefit in terms of clinical benefit with single agent therapy, either enzalutamide or bicalutamide, and especially in those using the AR profile. Unfortunately, we never saw this published, and many of the randomized phase trials have been canceled. But it did look like there was some single agent activity in those patients that had at least IHC expression over 10%. So looking at some of the exciting ADCs that are emerging in triple negative, there have been some trials looking at GPNB. This was the METRIC trial, which unfortunately was negative. Trials with LIV-1 are actually ongoing. But we know that TROP2 expresses itself on probably over 90% of triple negative breast cancers, as well as other breast cancers as well. The most important thing here is the payload. So this is SN38. This is the active metabolite of irinotecan. So this drug is called sacituzumab govitecan and did receive recent FDA breakthrough designation. Now, why this is so interesting is that irinotecan, 10, 15 years ago, there was work published in JCO by Edith Brez. So clearly, irinotecan is actually quite active in breast cancer. It's just that it was quite toxic and difficult to tolerate. But here you can see that the ADC delivers up to 136-fold more SN38, the active metabolite. So we could argue it's not surprising that we're seeing such impressive results that warranted FDA breakthrough designation. This is the single-arm phase 2 data that was published in New England, median PFS of 5.5 months in a heavily pretreated population and a survival of 13 months. And as I said, got accelerated approval in April, just 2 months ago. This is the confirmatory phase 3 trial, the ASCENT trial. So this is sacituzumab versus standard of care or treatment of physician's choice. So just so that you know, sacituzumab is given IV days 1 and 8 every 21 days. But it was stopped due to compelling evidence of efficacy, and we obviously hope to see the results by the end of the year. I think a pathway that you're all quite familiar with is the PIK3CA-AKT pathway, and certainly in ER-positive breast cancer, this was in a lot of excitement due to the activity of PIK3CA inhibitors. Few notes I just want to comment on is a lot of people say to me, well, this is just in the LAR subtype. No, you actually see the PIK3CA, PTEN, AKT alterations, as you can see here, across all the different subtypes of triple negative. And in fact, here you can see that, yes, the AKT1 mutations are more common in the LAR, but it's also seen in basal LEG2. So again, activation of this pathway is not limited to the LAR expression subtype. We know now that AKT is an important nodal point. This drives carcinogenesis. And we have 2 proof of concept phase 2 trials, one with ipatasertib, which is the LOTUS trial, and one with CAPV in the PACT trial. Both of these randomized phase 2s showed an improvement in progression-free survival with impressive hazard ratios 0.4, 0.3, with paclitaxel versus paclitaxel plus AKT inhibition. So again, you see here, this is specifically in the biomarker positive or biomarker altered patients in triple negative. Very recently at ESMO Breast, we saw the final OS results from the ipatasertib trial, where we saw a clinically meaningful 9-month improvement in overall survival. But obviously, this is randomized phase 2 data. We await the phase 3 IPATUNITY data, which should be presented and available by the end of the year. I think, as I mentioned to you just a few minutes ago, the most exciting combination that we're looking at now is looking at paclitaxel, atezolizumab, plus ipatasertib. This is a triplet phase 1b study. And as you can see here, the waterfall plots, overall response rate of 73%, independent of PD-L1, independent of biomarker status. So the theory is here that basically you can overcome potentially resistance, or you can make these cold tumors hot with the combination. So you really see quite impressive synergy. So this formed the basis for the ongoing IPAT 170 study. And I didn't show you a lot of study designs in this presentation, but I want to highlight this because this may be the future. We were mandated by the FDA to have 2 cohorts because now for first line, PD-L1 positive, at least right now by SP142, is the standard arm for triple negative breast cancer patients. So there's cohort 2 looking at atezo plus PAC versus the triplet adding ipatasertib, and then the other cohort, which is PD-L1 non-positive. So finally, looking at the immune or inflamed subtype. Now, you've heard a lot of talks about this, so I won't spend a lot of time going through it, but I think you've known for quite some time that triple negative breast cancer is the one that has the higher mutational rate. But in fact, we know that it's perhaps the quality of mutations, not necessarily the quantity, and thus there may be other subtypes that benefit from immune checkpoint inhibition. We also know that earlier is better in the treatment, and that's partly seen because in earlier line, we see a higher rate of TILs, and across all the drugs you can see there, the higher rate of TILs, the earlier you treat, the more likely you are to get a response, but the number of patients that benefit is small. And hence you see ongoing trials combining chemotherapy with immune checkpoint inhibition. So this is looking at nab-paclitaxel plus placebo versus atezolizumab, the PD-L1 inhibitor, plus nab-paclitaxel. I want to highlight that 41% of these patients were PD-L1 positive in the immune cells using SP142 testing. This is the PFS data that many of you have seen already, showing a modest improvement in PD-L1 positivity patients, hazard ratio of 0.62. But I think most notable is the improvement in overall survival. As you can see here, hazard ratio of 0.7, an improvement from 18 to 25 months. Obviously, due to some challenges due to the hierarchical testing, we are eagerly awaiting the final OS, but also the Impassion 131 results, which will look at paclitaxel plus atezolizumab. A few weeks ago, I think all of us saw the Keynote 355 data. So this is different in that the control arm used either carbogem or taxane, which could have included weekly paclitaxel or Abraxane, plus or minus pembrolizumab. What you see here is an obvious improvement, especially in the PD-L1 CPS score greater than or equal to 10. So this is what we've seen used in the lung literature. This is using the 22C3 assay. And here you see an improvement in terms of progression-free survival over several months, so up to 4 months improvement with impressive hazard ratio that was statistically significant. So again, we wait for the overall survival results for this. And I think we're also eager to see what happens with the CPS 1 to 10% patients. So what are we left with in the first line setting of IO? What are the sort of outstanding questions? Again, we wait for the OS results. We will wait for the other ongoing trials. Does the chemo backbone matter? Which patients are more likely to benefit? Which companion diagnostic and what's the cutoff? And does this extend to other breast cancers? Certainly, I think we've all heard about the role of potential TMB. This was presented last year at ASCO, where over 93% of patients had 3 or more prior lines of treatment. They looked specifically at TMB, so from 9 to 37. And as you can see here, there were patients, even that were heavily pretreated, both HER2 negative and HER2 positive, that benefited from single agent immune checkpoint inhibition. And as you can see here, as many of you know, the FDA recently approved pembrolizumab for patients with greater than or equal 10 TMB. So I think for breast cancer, the response to IO is a very complex interplay of factors. I've added a few here to the typical blankogram, which is the APOBEC signature and TILs. And likely the best way to identify these patients is not just one single biomarker, but is likely a composite of different biomarkers. And maybe we can predict who needs single agent therapy, who needs combination therapy. And so finally looking at, as I mentioned before, does combining PARP with immune checkpoint inhibitors help? And certainly with looking at PARP inhibition and also chemo, we've actually has been shown clinically that you activate the STING pathway and hence expression and release of type 1 interferons, and then expression or infiltration of effector T cells. So this is a proof of concept work by Susan Domchek in the Mediola trial, where she showed this little run-in of olaparib, again, going back to the point I just mentioned, potentially can activate STING, then you add in durvalumab, and you can see here quite impressive waterfall plots, not just in triple negative, but across all the breast cancers, but these were germline BRCA patients. Now, one of the criticisms of these trials is that are you getting more than just the response you'd see with just PARP inhibitors or just IO? But in fact, what you can see here from the Tapatio trial, which combined PARP and IO as well, is that these responses are actually quite sustained, which with PARP inhibition alone, you don't always see. So I think we're quite keen to see the results of some of the ongoing newly designed phase 3 trials. Our group is actually looking at the DORA trial, which is actually trying to select out patients that are platinum sensitive and then randomizing them to olaparib or olaparib plus durva. And so again, this may give us some more information about how best to sequence these drugs, because it's very hard to do this preclinically. And finally, I think many of us were very excited to see the results presented by Leos Putzai, the I-SPY 2 trial. So as you know, this is a Bayesian adaptive model design in the neoadjuvant, so early breast cancer setting, where paclitaxel is the standard arm. The adaptive randomization brings in these novel treatments. And this one here that was presented at AACR was the paclitaxel plus durva and olaparib, so IO plus PARP inhibition. And what Leo showed was that across all these HER2 negative subgroups, in fact, there was a high probability of success in a phase 3. Most notably here, you can see in the triple negative, predicted probability of success in a phase 3 went from 27 to 47. But in fact, across all these different groups. But I think what's actually most interesting was what he showed us about this one predictive, pre-specified predictive marker. So this is in the ER positive HER2 negative subtype. He looked at the MammaPrint ultra high, so what is termed MP2, which you'll have to read about in greater detail in the MPJ paper. But basically, you're taking a highly proliferative ER positive breast cancer. And here you can see the predictive probability of success with the durva-olaparib combination was 64 versus 22%. And I show you this to highlight, again, it may be pathways. It's just not ER, PR, HER2 negativity. There's clearly more that drives, potentially allows some therapies to work. So going back to this original configuration, and I mentioned, as I said, these are the different clinical subgroups. So now we can test for germline BRCA, an extended panel. We can do PD-L1 status. Right now it's SP142, but it might be 22C3 pending OS results, TMB, MSA high, perhaps TILs. We can do IHC for AR positivity. In the future, we'll see the results from these AKT inhibitor trials. For the antibody drug conjugate, you do not need to measure TROP2 in these trials. All patients were eligible. But we also need to continue looking for these patients, entering these patients on trial, looking for these very, very rare NTRK mutations. I think I showed you at the beginning of the lecture how many of these patients actually may have HER2 mutations. It's worth looking early for these patients. So I was telling Mafalda as you were all waiting to get on the call, in my clinic, triple negative has become very exciting. Now, I must confess, I looked at one of my lung cancer colleagues' algorithm. It was slightly more exciting. But we're gonna get there, and I think over the last 20 years, or you could argue even 10 to 15 years, we've come a long way. But in the clinic, what we do at our center is we look at PD-L1 status, right now reflex testing by SP142. And if you're PD-L1 positive, and let's say germline BRCA as well, you have the option of chemo plus atezolizumab or PARP inhibitor or platinum. There's a lot of debate and controversy about which one you should use first line. Many would argue that this trial was really just a first line trial, and so they'll give immunotherapy first line, and then they'll go to a PARP inhibitor second line for the germline BRCA patients, and then third line sacituzumab if it's approved and available in your country. Now, for those patients that are PD-L1 negative, and let's say germline BRCA positive, PARP plus or platinum, but if they're germline BRCA negative and PD-L1 negative, it's standard chemotherapy, and then potentially sacituzumab if available. So what you need to do is still consider these patients for trials for all lines of therapy. Early NGS if you work in a center where the patients can get on a study. We hopefully will see some incorporation of AKT inhibitors in the near future. People always ask about AR. I think you have to get them through standard chemotherapy first, but if they do have expression of IHC-AR, it's reasonable to consider an AR receptor antagonist. There are trials now for low ER and low HER2, such as TDXD. And then again, remember to repeat the biopsy wherever possible. So I want to leave you with this colorful diagram that Leos Putzai and his group put together. There are numerous trials ongoing combining different immune checkpoint inhibitors with all different kinds of other new targeted therapies. And I do think this is the future. I'd like to thank and acknowledge all of the colleagues who I share slides with whom these slides would not be possible. And as well as I said, my lung colleagues who helped give me some inspiration to where we could go with triple negative. And once again, thank you, and Mafalda and Sonia for the invitation.
Well, Rebecca, thank you so much. It was an exciting and great talk, and we cannot clap because we are in Zoom, but I'm sure that everyone is clapping at home. So it was really a great talk. I just want to remind you that you can make your questions if you exit the all screen mode, and you have a link on the bottom of your screen to make the questions. And while people warm up, I will just, we have received a couple of questions, and I think that your last slide with your algorithm that I want to study and to look at it more carefully. But I think the first question goes a little bit in line what you were showing there. So I think it's from Alish Prat, the question. and, and he asks that beyond germline BRCA1 and 2 and PD-L1 immunohistochemistry, what do you think it will be the third biomarker to enter the clinic in metastatic triple negative breast cancer?
So, I think it's a bit of a sort of trick question. So I'm hoping that by the end of the year, we'll have the results for IPAT 130. And I think if we're successful, then we will be screening for PIK3CA, AKT PTEN aberrations. Now, 2 of those we can get potentially with liquid biopsies, and the concordance is quite high. Obviously, loss of function mutations such as PTEN are much more difficult. You can't really measure them in the liquid biopsy. But yeah, the next biomarkers, if the AKT inhibitor trials are positive, that would potentially be the next one. And I'm hoping we have a better way of identifying patients that benefit from immune checkpoint inhibition. So I think more of us, will probably look for those MSA high TMB patients. But in terms of routine care, I think those are the ones.
Yeah, so you just mentioned one very important point, and we will have a talk about liquid biopsy later this afternoon. But the question I have, and which I think so much, is, we know that biology is very heterogeneous, but we don't know the longitudinal heterogeneity of triple negative breast cancer, let's say. So if one drug or one combination is approved in first line, so what happens to the tumor, and what would be the next rational combination? So it's one of the questions I have regarding the sequence about all these new therapies that are reaching the clinic. You just mentioned immunotherapy versus PARP inhibitors in patients with both PD-L1 and germline BRCA. But I mean, how do you envision like such, tailoring the treatment of these patients across the metastatic breast cancer history?
So I get the great question, I think, and like you said, that's one of the common ones that comes up. So I think the first one of, if you have a germline BRCA and PD-L1 positive, I think many of us prefer to give, there's more data, there's more evidence to giving first line immune checkpoint inhibition with some long durable benefit that is, quite pronounced, that hopefully we'll see with Pembro as well as we've seen with Atezo. And so that most of us, because there's data benefit in second and third line for PARP inhibition, I think many of us would go that route. But back to your sort of question about stability and looking at, the evolution over time. So I think what's interesting is you're looking at the PIK3CA, PTEN, and AKT mutations. Those appear in triple negative anyway to be more stable than what we see in ER positive, where, you look at patients with CDK inhibitors, and there seems to be a big change in terms of their mutational profile after exposure to CDK. I don't think we have that data yet in triple negative to understand it, the impact of treatment specifically affecting that pathway, but certainly from early to metastatic doesn't seem to be a lot of change. So I think that's the one thing. I think it's important if we can, wherever we can in trials. So in the DORA study that we're doing with Durva and Olaparib, we've got blood at several time points. And that was one of our goals, is to understand, because I think Chris Lord and his group are really trying to understand, like, why don't all germline BRCA patients respond to PARP inhibition? And certainly with the IO and PARP combination and Susan Domtek's work, it really dichotomizes. There's a group of patients that are very quickly resistant, and then there's a group of patients that have these long durable responses. So if we can identify who those patients are, we'll get a sense. Is it reversion mutations? A lot of these patients may benefit from ATR inhibitors. So despite progression on PARP, there may be other drugs that target this pathway that might be a benefit. So I think we do have to do serial biopsies to understand what's happening in the tumor in these patients.
Yeah, that's a great area of research for the next years, definitely. So I have another question here coming from the assistant that asks you, do you see a role for adaptive T-cell therapy, metastatic triple-negative breast cancer?
Listen, I certainly hope so. And I think there are clever people out there looking at it. I think the hard thing is that you look at all the patients that have been treated with these different treatments, the number that have been treated versus the number that so far that benefit across all of the studies that they're doing is still quite small. And I think the money and the labor involved to try and do it is quite intensive. So I certainly hope so, but I won't begin to predict that one quite yet.
Yeah, sure. And we have another question. It relates to a situation that we know it's very devastating for triple-negative breast cancer when it arises. It's brain metastasis. So we have now the evidence from a breast cancer, a HER2-positive metastatic breast cancer trial that showed very nice results in this population. Do you think patients with active triple-negative breast cancer brain metastasis should be excluded from clinical trials, or should we pay more attention to this population of patients and try to improve their prognosis?
I think we try to include them in trials. I think one of the things that's interesting is if you look at any trial, as you and I have been involved, the screen failure rate for metastatic triple negative trials is easily at minimum 30%. And that's because we pick up asymptomatic brain metastases. So, I think we need to, again, like other trials do, patients that are symptomatic and progressive, no. But patients who have limited disease that is controlled or can be easily treated, I absolutely think that those patients should be included, because we're already eliminating a good third or more of patients into trials. Plus, I think we need to actively monitor which drugs potentially are active in the CNS, because I don't think we always know that. Sometimes these are found by accident. There aren't that many, but I definitely think they should be included, and we need to investigate further.
Well, Rebecca, thank you so much. I think we could go forward for another hour, I think, but I'm being pushed from the team here to move forward. Thank you so much for your time. Thank you for your very nice presentation. And I hope to have you in Barcelona in person soon.
And Rebecca, thank you so much for the algorithm that you've made us just for us. So I think it's great to have it. So thank you so much for having this time and doing it. I think it's great. I mean, you could publish that, and
we'll get working on it.
Yeah.
Thank you.
Thanks,
Thank
everybody.
you so much.
Thank you.